Oh, we're live. My name's Dr. Fleur Cattrall.
My name is Dr. Kokum Jayasinghe.
And we are Melbourne IVF fertility specialists. Today, Kokum is going to walk us through unexplained infertility. Now, this is a diagnosis which many couples find very difficult. We're keen to find the answers too, and that is why we maintain a strong research and innovation focus at Melbourne IVF. So tonight, we would like to cover what are the reasons for not falling pregnant, and what are the tests that we do to find the answers, what are the treatment options, and then we'll answer any questions you might have. So, Kokum, unexplained infertility is an area that you have a particular interest in, don't you? Would you like to share with everyone how this came about?
Absolutely, Fleur. I think there's 2 points I want to highlight there. Infertility itself, having a diagnosis of infertility itself is hard enough, let alone when you have given the diagnosis of unexplained infertility, that can be quite emotionally challenging for people. Sometimes we cope better when there is a reason behind the condition. So I suffered from the condition myself, so I understand the emotions behind what our patients feel when they have the diagnosis. And I have been through the treatment options and I have been through the treatment myself. And luckily, I am successful and I have 2 lovely boys now. And also, my experience itself has shaped me my career options, and it has made me choose my path and made me the doctor who I am today. So this is a topic that is quite close to my heart.
Very good. Now, I think we should just talk about what the actual medical definition is of unexplained infertility.
Right. So, Fleur, the diagnosis of infertility we make when a couple have unprotected intercourse and not pregnant after a year of a pregnancy. And to make a diagnosis of unexplained infertility, there are 3 main areas we need to focus and rule out is not the cause. So taking you through one by one, the first is ovulation. We want to make sure the female is ovulating. The history...
We might just share some visuals with everyone if you like. Yeah. Can you see that?
I can't see the visuals yet. Okay. Yeah. Yeah, okay. So the history itself, if the female have regular cycles, the history itself is suggestive of ovulation. If we have any doubts or we want to time the ovulation, certainly they can do this home ovulation at home. And further to that, we can do cycle tracking, looking at the development of eggs and the size of the eggs and doing a blood test, the progesterone level, in the second part of the cycle to confirm ovulation has happened. And moving on to the second one, Fleur, is the semen analysis. So we want to exclude there's no male factor, and then basic semen analysis, looking at the concentration of sperm, the movement of sperm shape, as we can see on the visual here, the sperm shape is an important thing, particularly the sperm head, to penetrate an egg and fertilize that. And the last thing we want to look in the basic semen analysis is the presence of antibodies. The presence of antibodies will slow down the sperm and make it difficult for the sperm to penetrate the egg. So that's how we would look at any constituting male factor. And the third part we want to exclude is the tubal patency and the uterine anatomy. Mm-hmm. And this can be done in 2 ways, either ultrasound based or through a laparoscopy. So I would think a laparoscopy is the gold standard because it has multiple other benefits. So basically what happens in a laparoscopy, it happens under general anesthetic. So patient goes to theatre under anesthetic and we put a little camera under vision to the belly button. Then we put gas into the tummy so we can lift up that tummy wall so we can do a safe procedure without touching the other nearby organ. one of the main advantages here, Fleur, we can see mild, moderate endometriosis that may not have been picked up by the ultrasound. Ultrasound certainly has a good sensitivity and a predictive value with a severe endometriosis, but the mild, moderate may not be picked up by the ultrasound. And certainly removing this mild, moderate superficial endometriosis does increase one's natural chances of fertility.
And part of a laparoscopy is often looking inside the uterus, isn't it?
Yes. So we would be doing the laparoscopy to start with looking at the endometriosis and things outside the uterus. Yes, how we start the procedure is definitely with the hysteroscopy. So hysteroscopy means putting the camera inside the uterine cavity, and we will be looking at any anatomical changes, or particularly if there is any adhesion that we can address at the same time, and we will be doing a curette and taking samples to make sure there is no chronic infection or endometritis that we can also treat later.
Mm-hmm.
So the most important thing there is putting some dye through that cervix and checking whether dye comes out of the teeth. So that is how we check the people
take. Your sound is very poor, actually. Can you speak quite loudly?
Sure. Any better, Fleur? If I come to the
I think it's a little bit better on this side than that side.
Fine. Yes. Can you hear me?
Yeah, it's still difficult. Just speak very loudly and clearly for us.
Right. I might bring the computer much closer to me. Yeah.
To explain to everyone, we tried very hard to improve this beforehand, but didn't quite get there in time. Now, can we go back to explaining to people can you go through this? So basically, it would be good to outline, so we know all the causes of why couples don't fall pregnant, and there's lots of tests that we can do. But what are the things that are happening at a microscopic level that you can go through to try and give a sense of all the things that we can't test for that might be the reason behind unexplained infertility?
Yeah. So basically what needs to happen, during intercourse, sperm gets into the upper vagina.
Okay, I'm going to stop this. How about come into my room and you speak in here? So we'll have to do something a little bit un-COVID friendly. And I've got to go and unlock the door. Okay, so Kokum, let's maintain a safe distance from each other.
We are still following the COVID rules and maintaining social distancing. So I will take you through what basically needs to happen for fertilization and pregnancy, and what needs to happen at microscopic level that we can't really see inside the body. So during intercourse, sperm get into the upper vagina, and they need to swim up through the cervix, through the uterine cavity, and through the fallopian tubes to meet the egg. So we assume they can do this, but they may encounter difficulties penetrating the cervix and swimming through the fallopian tube. There can be mechanical difficulties there. An egg, once get released through the ovary, needs to be attracted into the fallopian through fallopian tube and the ampular part of the fallopian tube through suction-like movements. So there can be, again, challenges and difficulties here. An egg is the largest, biggest cell in the body and not very mobile. So it waits here until it meets a sperm. And that's where the fertilization happens. Once the fertilization happens, the embryo now need to move through the fallopian tube and come and attach into the uterine cavity. And there can be some, again, obstacles and challenges with this journey and moving through the tube. Once it reaches the uterine cavity, implantation needs to happen. That's again another area that's subtle difficulties or that's things that we cannot easily see and detect could happen and contribute to subfertility.
Okay, fantastic. So can you tell couples what are the things, so we'll move on to sort of what you do in this situation when there's been no explanation. What are the things that couples can do to boost their chances of conceiving naturally?
Absolutely. So I think that is where a good point to or good place to start there is looking at your general health and optimizing the general health. And we can start with diet and lifestyle. So in terms of diet, I think there are do's and don'ts. It is easy to look at it like that. So the do's would be maintaining a healthy weight and healthy eating habits. So healthy eating habits, I would say, over and over through research, Mediterranean style diet has shown to be beneficial. So Mediterranean style diet mainly would include olive oil, whole grain, and lots of fruits and vegetables, and antioxidant-rich berries and citrus-type food, fish, eggs, and nuts, that kind of food. And the don'ts there with food would be food high in sugar, junk food basically, and a lot of simple carbohydrates, and smoking and high amount of alcohol. So they are definitely in the don'ts.
So Kokum, the aim is optimal health, is that right?
Absolutely.
And are there any sort of general medical conditions that can contribute to unexplained infertility, do you think?
Medical conditions, I would say uncontrolled. So things like uncontrolled diabetes would be a contributing factor. And thyroid conditions that is not under control would need to be looked at and medicated.
And there's lots of grey things, aren't there, like celiac disease and things that are mentioned that the evidence isn't very clear. Would you say that the goal generally is just to aim for optimal health?
Absolutely. Yes. So it is especially if there is any background medical problems, it is wise to see the GP to start with and to get these tested and get them under control. And we shouldn't forget about the folic acid flare. For folic acid in the prenatal period is quite an important thing to reduce the risk of neurotic defects in the offspring.
Now, we see a lot of couples that bring an awful lot of different supplements and herbs and things to our rooms to show us, or at the moment it's online. What do you think? What's your advice about all these things that we would consider non-evidence-based?
So my usual advice is it is important to have a healthy relationship with the other allied health and practitioners. So as long as there is no active hormones, if there is any active ingredients and active hormones, they may actually contribute to the cycle regularity and ovulation. Mm-hmm. I would say on top of the supplements, I would read the label and I would look at how much folic acid is included in these recommended supplements. And if that is not adequate, I would suggest taking extra supplements. How do you approach that, Fleur?
Look, I worry about all the things that people take that don't have good evidence, because when something doesn't have evidence, and this is the reason that at Melbourne IVF we're very keen to find the answers in an evidence-based way, but things can be beneficial or they can be harmful if you don't have good studies. And I guess one of the things that you're not looking at is the doses that are appropriate for these things, and also what else is in there. There's lots of sort of even the plastic capsules on the tablets. When you're taking lots and lots of them, you might be doing a disservice for yourself. And along those lines, there's lots of evidence now supporting not heating your food up in plastic containers, using plastic water bottles, all these endocrine disrupting chemicals, as we would call them, are in our environment. And we probably need to aim for things to be as natural as possible, maybe even eating organic food. So without being too finicky about things, I mean, we're always exposed to chemicals all the time, but you do the best you can with the information that you've got. So next, I think we should go on to the treatment options. So I think you've got the mouse over there. So I'll let you screen share for everyone. And you press screen share and then we'll move down. And we start here. And this side. And next, we'll just move along here. Yeah. Okay, so cycle tracking. Tell me about that.
So I will take one step back there, Fleur. The most important thing when you are dealing with a couple with unexplained infertility is to get them involved with the treatment option and explain their options and choices. So not many are keen to jump straight to IVF, and some would like to actually explore a little bit more about their menstrual cycle and to understand where is the fertile time, and to confirm that they have been covering the fertile period of the menstrual cycle. Sometimes also, Fleur, when they have been trying for about 2-3 years, they are sort of getting tired of having sex. And so not frequent sexual intercourse during fertile time might be certainly a contributing factor. So we do this thing called cycle tracking. It is more actually for the confidence of the patient and to make sure that she understands the fertile time of the cycle and there is no hesitation or confusion that she's covering the appropriate time. So what I personally do, depending on the cycle length of the patient, about 2 days before the predicted ovulation, invite her to come for an ultrasound scan. So through a transvaginal scan, we can check what's happening in her ovaries. And what we are really looking for is developing a dominant follicle. So this would be somewhere close to 17-18 millimeters. Then we would also observe the endometrial lining, because that's an important point, important observation. And we expect this to be above or around 8 millimeters and a particular appearance called trilamina. We would also notice most of the time the presence of cervical mucus. And I usually suggest a trigger for ovulation, because that is easy to predict the ovulation and gives them a fertile range. And also to tell her that this is the day of the ovulation, predicted ovulation, and you're fertile a day after the ovulation. So they are confident that they have been covering the fertile time and relax afterwards to say, now it is waiting time to see whether pregnancy has occurred or not.
So it gives them confidence that they're covering the fertile time.
Absolutely, yes.
Do you get many questions, I know you do, about having sex and position, anything particular I should do afterwards, etc.?
Absolutely. I think the practical points to cover there, Fleur, most of those things are myths about the positioning and things. Frequency-wise, the physiological points the patient need to understand, sperm in the body lasts up to 4-5 days. So egg, on the other hand, is viable only 12 to 24 hours once it is get fertilized. So what we want is to get sperm in before ovulation happens. So there is a good chance for this egg and sperm to meet. Positioning does no difference at all, because the sperm is biologically able to swim, doesn't matter the direction, up or down, and go and meet the egg. So hanging upside down after intercourse definitely is not going to increase your chances. And it is, in fact, and sometimes you get the question, should I be lying in bed for the next 2 hours? In fact, it is a good idea to go empty the bladder for the female to reduce the risk of urinary tract infections. And another thing is the presence of mucus. Some women are sensitive to notice the change of mucus and the presence of mucus, and some are not. And this is another observation we can make through ultrasound. It is good if you notice mucus, but you not noticing doesn't mean there's an issue, doesn't always necessarily mean there's an issue with the cervical mucus.
Yes, people worry about that, don't they?
Yeah.
So after cycle tracking, I guess it's the dilemma about how invasive you go with the fertility treatment. So
absolutely.
Can you talk us through the difference between IUI and IVF?
Yes. So the two most important prognostic factor for a couple presenting with unknown factor infertility is the age of the female and how long they have been attempting to conceive. So which method you choose will actually depend on these two things, and also the patient's likes and dislikes and their comfort. So the difference of the two methods, IUI and IVF, is the invasiveness and how much involved the whole treatment is. In IUI, what we do, Fleur, we do mild stimulation. We use FSH injections with idea of getting about 1 or 2 eggs, because it is a balance between exposing the patient to the risk of multiple pregnancy. So stimulation is given at a mild level, aiming for about 1 or 2 eggs to develop. And through ultrasound monitoring, when the eggs get to the right size, we give the trigger injection. And so this way we can predict the day she ovulates. And on the day she ovulates, we get partner sperm concentrated into a very small volume and inject that inside the uterine cavity, closer to where the eggs are. So it has a less distance to swing.
Now, women often wonder if it's going to be painful, don't they?
Absolutely. So this is actually not a painful process. So if you tolerate a speculum examination, which is the common encounter for a speculum examination is a pap smear. If you tolerate your pap smear examination without any trouble, you're not going to feel anything more than that. And the catheters we use are absolutely tiny, and most women don't feel these catheters being inserted through the cervix.
Okay, so IVF involves a lot higher doses of injections, doesn't it?
That's right.
And so I'll just move on to the ultrasound appearance. Do you want to walk through what this is?
Yeah. So in IVF, the idea is different. The concept is different. The idea is different. We want to give a higher dose of FSH or the stimulation because we want to stimulate the ovaries and grow multiple follicles. Where we have the control to avoid multiple pregnancy is we get embryos and we only transfer one at a time. So that is how we control that risk of multiple pregnancy in IVF. So with higher dose, we get the ovaries to produce a reasonable number of eggs. What we are aiming for is somewhere around 8 to 10 eggs. And when these eggs get to the right size, we do the egg collection. For egg collection, we take you to theatre because we put an ultrasound-guided needle through the vagina and collect these eggs through there. So there won't be any suturing and cutting on the tummy. It is done through the vagina. Yes, it is uncomfortable during the procedure. That's why you're under anesthetic. So you're not going to feel any discomfort during the procedure, and you wake up when the procedure is done. So on the day of the collection, when your partner comes and give the sperm sample, so obviously we have checked the sperm sample to be normal before. So we put the eggs and sperm in a dish that afternoon and let them fertilize themselves. Check in the morning to see how the fertilization, because not all eggs get fertilized, that is standard. And we would see how many eggs are fertilized and develop into an embryo the next day. And in Melbourne IVF lab, there is certainly some advances and routine things we do. Do you want to highlight and explain some of those to our listeners?
I just had a really nice image of the embryo skirt, which is missing, but we grow the embryos 24/7, 5 days, watch them every 5 minutes. That basically continuous monitoring, and that allows us to select the best embryo. We're running a trial at the moment looking at whether artificial intelligence might actually choose the embryos better than the grading system, which is developed by our scientific director as the world standard. So maybe with his involvement in the artificial intelligence trial, we might actually find it's better. We're also running an antioxidant trial, also Professor David Gardner's work, which might actually improve the pregnancy rates. As a standard, we use embryoscope, embryo glue. So I think we're at the top.
We are definitely, and
in terms of what you can offer.
That's right, and definitely we get asked about the embryo glue, and that is a part of standard treatment in our lab.
Now, I've got some questions coming through here.
Sure.
Do you think STIs, for male or female, could contribute to unexplained infertility?
I think the simple answer is yes, they could. And depending on what type of infections or STIs we are talking about, particularly chlamydia is a common STI, and previous history of chlamydia could have contributed to some tubal damage. So even though the simple tubal patency could have shown the dye coming through the tubes, there could be some subtle damages there that is preventing sperm motility through the tubes or the embryo to move through the tubes and implant into the uterus.
Because there's little fibres in the fallopian tubes, aren't they? And they beat here along, and they're microscopic, and they could be damaged by infection, but we don't have any tests for that.
Yeah, we don't have any test other than simply putting the dye. So just seeing the dye at the end of the tube may not detect subtle changes like that.
Another question for you. What could it be if my husband has been told he has fantastic sperm, but when we did IVF, the sperm did not penetrate the egg?
So, sometimes, Claire, doing an IVF cycle can be a diagnostic test for couples with unexplained infertility. And we may notice reduced chances or reduced fertilization numbers, and very occasionally no fertilization at all. And this can be a sperm or an egg issue, and particularly if we were told this sperm test was absolutely normal and fantastic, there could be some issues with the eggs. Because with the eggs, there is certainly a zona pellucida or outer ring that need to be penetrated by the sperm to fertilize. So I would assume there is a possibility there was a subtle changes like that or an egg quality that we could not be detected or anticipated before until we observed these in the lab.
All right. Thank you very much, everybody. It's 7:30 and Kokum and I have to get back home before curfew at 8 o'clock in Melbourne. So thank you very much. I hope that was helpful. Very sorry for the audio. But if you need help with unexplained infertility, then I would recommend that you see Dr. Kokum Jayasinghe.
Thank you very much, Fleur, and thank you everyone for joining us today.
Okay.